Good afternoon and welcome to the weekly briefing from ISAG, the All-Ireland Independent Scientific Advisory Group on COVID-19. The COVID-19 pandemic surge is on across the world. There have now been 200 million reported cases worldwide and 2.25 million deaths. In Northern Ireland, the official toll of death from COVID, according to the death certificates completed by doctors across the province, has now exceeded 3,000. The figures compiled by the Northern Ireland Statistics and Research Agency provide a broader picture of the virus's impact than the figures from the Health Department in Northern Ireland. This means that deaths from Northern Ireland in the last 18 months are slowly approaching the estimated number of 3,500 deaths from violence during the entire Troubles. In the UK, there have been significant drops in new cases. Hospital admissions and deaths, however, continue to cause concern, particularly within the NHS, which remains under great pressure. The early progress achieved by the UK in rolling out vaccination against COVID has slowed, and the Republic of Ireland has overtaken the UK in the proportion of the total population vaccinated. The UK appears to be on the verge of providing vaccinations for 16 and 17-year-olds, but this still leaves a substantial group of young people aged 12 to 15 who will not be offered the vaccine in Northern Ireland, but will be in the Republic of Ireland. This is yet another example of the failure of the harmonisation between Northern Ireland and the Republic that was promised in the Memorandum of Understanding, and doesn't help us move forward in getting the virus under control across the island. In the Republic of Ireland, the total number of cases reached the level of 300,000, and that's the main theme for our meeting today, what that means, what the implications are for us going forward. There does, however, seem to be an assumption more widely that the situation with the virus is stable or coming under control, and there are still pressures to relax more and more restrictions. This is a dangerous assumption to make, that it's under control. And I'm going to hand over to Professor Anthony Staines, who's going to take us through some of the data and some of the knowledge we have about how things are happening for us at the moment. Anthony, over to you.
Thank you very much, Gabriel. What we're going to talk about today is not COVID-19 league tables. I think that's a fairly pointless exercise. We've seen the fascinating announcement from my own political party that we were now 0.1% ahead of the United Kingdom in vaccinations. And this is not a race. This is not about which country can win against COVID. I think the message we want to get out today is that everybody needs to work together to deal with this appalling illness. So if we start by saying, where are we and how do we get here? Next slide, please. We have been, in both Ireland and Europe, parochial and universal, but mostly quite parochial. So we've tended to look to other European countries, at other European countries. And much of our COVID-19 response was driven by what could be fairly described as a woeful response across the EU. And that has been influenced, among many other things, by lack of serious public health input at Commission level. So there was no central European public health strategy for dealing with this pandemic. Much of the rest of our response has been a copy of the UK response, and it's been driven by the short-term interests, particularly the airline industry, which is a very significant employer. Many of the people in my town work there, and it matters, and corporations who want people to be able to travel in and out. And this attention to short-term interests has been very expensive. Next slide, please. This is a tweet from Tony Holohan, who's our Chief Medical Officer. And he describes the milestone of 300,000 cases as of last Saturday, which is pretty astonishing as a number for a country with a population of about 5 million. That's an awful lot of cases. The positive part of it is the uptake of vaccination. And the same day that tweet came out, we'd seen the photographs of mostly young people queuing outdoors from 6 a.m. to get vaccinated. And that is also impressive, and it's also important. Next slide, please. I'm going to very briefly just talk about our current situation in the Republic first. And in the Republic, the highest rate of cases per day continues to be in those aged 19 to 24, and it's rising somewhat in those aged 13 to 18. At the moment, people not aged 0 to 12, their cases are going up slowly but relatively stably. So there's no sign of a major outbreak in primary school age children. But in older children, there is a substantial number of cases. And those children are not presently at school. Today is a nice day. The last few days have not been so nice, but I suspect they're mostly outdoors. Next slide, please. Situation in Northern Ireland is not that different. The age groups are a bit different, but the rates are high across all age groups and have levelled out over the last few days. And we don't really know why they've levelled out over the last while, but they have, which is good news. Next slide, please. This takes us somewhere else. This is the number of cases per million globally. And I draw your attention to the very, very dark belt of cases stretching through Russia to Europe. And when you look at the spread of COVID-19 over time, this infection arose in China, spread from there to Europe, spread from there essentially all over the world. So the world has paid a very heavy price for the failure of Europe to contain COVID-19. Next slide, please. These are the UK figures in a little more detail over a longer time period. And you can see the difference, the stark difference between Northern Ireland and England, and the difference again between Wales and Scotland. We really seem to be looking at quite different patterns of behaviour. Obviously, the United Kingdom, most of the United Kingdom is England, so the pattern in England dominates the United Kingdom. But there are quite substantial differences between the constituent countries of the United Kingdom, some of which we understand. They reflect the different decisions made by different governments, and some of which we just don't understand. Next slide, please. If we look at where we are globally, we're having a large number of cases, not as many as the United Kingdom, where cases have begun to fall over the last month or so, but around the same as the United States, and much higher than most other European countries. So we have a substantial problem with COVID-19 in Ireland. And I've picked these countries for a reason, and it'll become clearer on the next slide. So these are cumulative cases per million people. So this is the measure of the burden of COVID on the population. The United States, 10% of their population have been identified as having confirmed COVID-19 cases. The true number of cases is larger in every situation. The United Kingdom, 85, 90,000 cases per million. Italy, 60 to 70,000 cases per million. Ireland, 60,000 cases. That's a very high burden of cases. Germany, Canada, India. We've been reading a great deal about the awful COVID outbreaks in India, but their cumulative case numbers are well below ours. And I draw your attention to the country at the bottom, Australia. One of the most disturbing features of reporting of the pandemic for me has been the glee in some people's voices when there are outbreaks of COVID-19 in places where the disease has been largely controlled. Places like Australia, places like Canada, places like Vietnam, places like New Zealand. And I don't think it's appropriate to be happy that they're having outbreaks, but it is appropriate to notice that the overall impact of COVID on them is much less the impact on us. Next slide, please. Moving on now from cases to deaths. Ireland is an unappealing shade of bright red, not as dark as the United Kingdom, which is beside us. and in a better state than several other large countries in Western Europe and the United States, but still unimpressive. There's been a lot of discussion about why the number of deaths in Africa has been relatively low. The view of people on the ground is that that's real. There are outbreaks of COVID in Africa. It's a serious problem in some places. But the actual number of deaths seems to be relatively low. And we can see in China, where COVID has been successfully contained, in Australia, in New Zealand, all places where COVID has been successfully contained. In Japan, in South Korea, where COVID has been perhaps less successfully contained, they've managed to keep the number of deaths down sharply. Next slide, please. At the moment in Ireland, we're having hardly any deaths from COVID-19, which is great. And that reflects our vaccination program. We are seeing the number of cases in hospital rising. And we expect, unfortunately, the number of deaths will begin to rise slightly following on from that. Other countries are doing substantially worse. I look at cumulative deaths per million. And again, this is a measure of the impact of COVID across the whole time span. We have done much better than some other countries in terms of deaths. That's been a tribute both to the quality of our clinical services and the fact that we never quite got overwhelmed. The clinical services in Italy did get overwhelmed more than once. But we've also had substantially more deaths than some other countries. So other countries have managed better than we have. And again, I draw your attention to Australia, which has had very few deaths. They have had deaths, and every death is a tragedy. But from a public health perspective, more deaths is worse than fewer deaths. Next slide, please. There has been a long and tortuous discussion about what does it mean to be dead? What does it mean to be dead from COVID? What does it mean to be dead with COVID? And the bottom line on this is that there are different ways of measuring deaths from COVID, but they don't show huge differences. There are significant numerical differences, the number of deaths. 130,000 in England versus 113,000, depending on your approach to defining death from COVID. But actually, that's still 113,000 deaths on the best scenario. And that's not positive. Next slide, please. Case fatality rates. Our case fatality rate is very, very low, which reflects the fact that very few people are dying, which in turn reflects the fact we've had a successful vaccination program. Other countries have not been so fortunate. Other countries, and I draw your attention again to Australia, where the vaccination program is substantially behind ours. Although they've had very few cases, more of their cases have died. So the number of deaths is much smaller than ours. But the risk of dying from COVID, if you get it, in Australia has been higher because they're not as well vaccinated. And a somewhat similar thing has happened in Germany. This is an interesting perspective. This is tests per case. So we're getting around 2% of our tests, 4% of our tests positive at any given time. It has been as high as 20% of our tests were positive at one point. So we're doing 5 tests for every case we identified. We're now doing about 18 tests, 19 tests for every case we identify. Australia has done a lot more testing, which has been an important part of their response to COVID-19. This is your vaccination picture. Everywhere should be really dark green. Nowhere is. The United Arab Emirates are doing pretty well. Mongolia is doing pretty well. Nepal is doing pretty well. Ireland is not doing badly, actually. Ireland's not doing badly at all, but we are a long way off the level of vaccination that will stop COVID spreading in our communities. And this is as true in Ireland, in Canada, the United Kingdom, in most parts of Europe. Next slide, please. We've heard a lot about the Delta variant. This is the last 2 weeks of data from a selection of European countries, India, Australia, and the United States. Essentially, Delta is the overwhelming story. There are other strains in circulation. Germany still has a substantial number of cases of Alpha and a rising number of cases of Gamma for reasons which are, I think, pretty obscure. India has quite a range of other variants in circulation, again, for reasons which are obscure, but Delta is the major variant. Reproduction rates. We've managed to bring our reproduction rates down, but it's still above 1. And as long as it stays above 1, the number of cases will not fall. So we're talking about 1,500 cases a day for the foreseeable future. Other countries are in a worse condition. Germany, for example, is in a worse condition. Although I think our number is probably going to come down fairly sharply over the next week or so. The United Kingdom, R has dipped below 1. Nobody knows why. That's good that it has dipped below 1, that there are fewer cases being generated by every existing case, but we don't understand why. We don't understand what's driving it. And we don't understand what might or might not reverse that. Hopefully nothing will reverse it. Next slide, please. Vaccinations. Australia has not done well in vaccinations. Their analysis was they had very few cases. They didn't need to vaccinate. Actually, they did need to vaccinate. Vaccine supplies were scanty earlier in the year. They're a lot more available now, and Australia is doing a crash vaccination program. Other countries have done pretty well. On this graph, we are just behind the United Kingdom. I think the very, 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 very latest data, we were ahead of the United Kingdom by a whisker, but actually there's no practical difference. We need to have 90% of our population vaccinated to stop COVID circulating, at least. We have 55%. Canada has just under 60%. Canada still has significant outbreaks of COVID. So we're doing well. Vaccination has had a tremendous impact on deaths, on hospital admissions. It reduces transmission, but it doesn't stop it, unfortunately. Next slide, please. So here's the figures. United Kingdom, Ireland, Italy. Canada is not on this. So this is the world's biggest countries plus Ireland. And what's worth looking at is some of the countries down the bottom of this slide. Nigeria, huge, 0.5% vaccinated. Vietnam, big country, 0.7% vaccinated. Democratic Republic of the Congo, second biggest country in Africa, no vaccines. Even Brazil, where they've had major outbreaks and they have a well-functioning health service mostly, 20% vaccination. Why does that matter? It matters because unless we can control this globally, we are vulnerable. We are vulnerable to reintroduction of COVID from different countries. We are vulnerable to the reintroduction of new variants of COVID from different countries. The United Kingdom equivalent of NEFIT, a body called SAGE, produced a report earlier this week about the potential for new variants of COVID-19. And it makes quite stark reading. We don't know what the range of new variants could be, but there's potential hazards there. Next slide, please. So this is Tony's take on it, and I think he's absolutely right. Vaccination and the uptake is bringing us to a turning point. Where he and I would differ is when the turning point is likely to be. The government's plan essentially is to race variants and vaccines. My colleagues and I are not so convinced that this is feasible. Next slide, please. We're seeing regular importation of cases. And I'm not sure we can stop the circulation of COVID in our population while that number of cases is coming in. Our key strategy has been articulated clearly as a race between vaccines and variants. Delta is about 10% less covered by vaccines than earlier variants, but 80% plus protection is absolutely worthwhile. It makes a very, very big difference individually and at population level. And we've been fortunate with COVID. The vaccines are really good. So the message from that is get vaccinated. And there's a nice analysis published this morning, which essentially says where we should put resources not into boosters of vaccine for people at high risk, but we should put resources into completing vaccines for everybody. From our point of view, from the parochial point of view, there's a real risk of a blow up of Delta in September when the schools come back. Potentially, and this is government modelling, not our modelling, thousands of cases a day, hundreds of long-term cases, most of which will be in children and younger people because everybody else is vaccinated. Scores of hospital admissions and unfortunately some deaths. And most of the deaths will occur in older, vulnerable, vaccinated people. Next slide, please. What we don't know is what's going to happen with the variants. We do not want to find out what's going to happen with the variants. We really don't. A combination of global vaccination and case number control are our best shot. Next slide, please. That's Delta. Delta is the cute, cuddly one. That's the other one. What happens if you feed them after midnight? What happens if you get them wet? Is the unknown variants. Delta, we think we can control. We think we can bring Delta under control and stop it. Controlling whatever emerges next, we might be lucky, we might not be lucky. And I would really prefer not to entrust global health to what is effectively a roll of the dice. Thank you.
Thank you very much.
I'll pass you back to Gabriel.
Anthony, what do you think the practical advice is that you would like to see NPHET coming out with to government? What do you think NPHET should be telling government to do?
I think, first of all, get vaccinated and complete vaccinations. Roll out vaccinations to school-age children. And as the evidence comes in, there are studies underway now of vaccination primary school-age children. As the evidence comes in from those, if the vaccines are approved, roll them out to primary school-age children as well. Keep the mitigations in place. Keep social distancing. Encourage people to wear masks in public transport. And you've had the discussion about what type of mask. We have been wearing this kind of standard face cloth masks. I think I've one here. We may need to wear what they call FFP2s or FFP3s, which are much more effective because this virus is highly infectious. But at the least, wear a mask. There's been a long conversation about socializing. Socialize outside. There's a serious discussion here about confirmations and communions. My take on that is the sacraments are important, but we can manage churches safely. Churches are big, highly ventilated buildings. The danger, and I think the reason that NPHET are against returning to communions and confirmations is the party afterwards. And the same is true of weddings. We can manage a wedding in a church, unless it's a very tiny church, but managing the safety at the party afterwards is a lot trickier. And people don't realize they can get COVID from people they know. You're more likely to get COVID from someone in your family than from someone you don't know. And that perhaps hasn't sunk in yet. So a lot of the public health messaging is around staying outdoors, doing the mitigations, ventilation in schools, carbon dioxide monitors in schools, HEPA filtration in schools. I think that's what the ventilation experts suggest to us. And keep as much of that going as we possibly can. And vaccinate. And at some point,
thank you very much. Now we have a smaller than usual but extraordinarily talented group of members of ISAG here with us to comment. So if you want to send in some questions on the Zoom, please do, and we'll try and pick those up. But first of all, can I go to Professor Helen Doak, please? And Helen, could you just talk a little bit about the situation in Northern Ireland, just to round out the picture across the whole island?
Yes, I'll say a few comments taking up really from where Anthony left off. Northern Ireland is not so different as was presented in the figures from the rest of the UK and from the Irish situation if you take a large view of it. But as Anthony said, global vaccination and case number control together are our best shot. And that's really the message that we have to have, is that vaccination is part of a virus control strategy. It's not enough all on its own. And that applies to Northern Ireland and it applies elsewhere. And I think to whatever I have to say, in a sense, it comes back as almost like a chorus line. So what do we need? We need vaccination within a virus control strategy. And it's that larger virus control strategy that's lacking. Vaccination in itself has been, in large part, extraordinarily successful. In Northern Ireland at the moment, we have two main discussions, I suppose, going on in the media right now in terms of what's happening. One is that, yet again, the health service is experiencing huge difficulties because of the rise in hospitalizations due to COVID and as well as staff isolation. These huge difficulties, not with the COVID cases, but with the delayed and cancelled surgeries for cancer and other serious conditions. So this is of huge concern. Obviously, the health service in Northern Ireland, even coming into this pandemic, was in a very fragile condition due to what had happened in the years previously. It's not resilient to a COVID pandemic at all. And again, we need to keep case numbers low, and vaccination has to be part of a virus case control strategy in order to protect our health service. Another discussion happening at the moment relates to the vaccination of young people. We've had the vaccination strategy as a whole has been very positive. The research and development was very fast. The rollout by the health service was excellent. The uptake by the population has been excellent. We've now got to the end of that in terms of approved age groups, to the 18 to 29 age group. And we found that they've rather plateaued off, or uptake is very much slower at around 60%, as opposed to well over 90% for the over 50s. So, the question is what to do about that. I think, first of all, one should be very positive about the fact that the young have actually engaged. 60% is a good majority. They have engaged with the vaccine strategy. As Anthony said, we need to get vaccine up above 90% and appeal to the young. There are various strategies, obviously everybody has heard being discussed. I personally don't think coercion is a very good idea, particularly with young people. I don't think it goes down very well with young people. Some sorts of incentives, perhaps, but again, I think that we should be appealing, we should be having the conversations so that young people can see what is the benefit to themselves in terms of prevention of long COVID and in terms of their return to face-to-face education being more likely and more soon, and what's the benefit to society. And I think young people are very acutely aware of justice and fairness and benefits to society. So we should be appealing to that conversation, but it's a conversation that's not easy to have with everybody at once. And perhaps, the types of incentives could also include giving donations to young persons' charities in terms of mental health or outdoor activity or environmentalism or whatever. But I think we need to appeal to their sense of being part of the community and an important part, and their natural sense of justice. But anyway, hopefully that will send vaccinations up, and vaccination is obviously a very important part of the virus control strategy.
Yeah. Could you just comment, Helen, if you would, on a feature in the north which there has been some talk of? People were turning up for their first vaccination, but not necessarily turning up for the second. Is that a feature, first part? And the second thing I wanted to ask you about was the emerging difference in terms of the vaccination of young people in Northern Ireland following the Westminster line. Northern Ireland has devolved health powers. Has there been any discussion about taking a decision in Northern Ireland to vaccinate from 12 upwards, and that would be the right thing to do in order to harmonise the levels of population immunity across the whole island? Has that emerged as an issue yet?
In terms of the first issue, whether people are coming for their second vaccinations, I don't know about that. Some other members of the panel might. I see. Andrew, would you like to address that? Yeah. Can Andrew come in?
I mean, it's very difficult to say for sure why that is. I think two reasons. One was the AstraZeneca announcement came just after they had announced it for over 30s. I had my jab about 2 days before the AstraZeneca announcement was made. So I think even as somebody that would definitely be pro-vaccination, it did make me a wee bit nervous. But after reading up about it, hearing that actually the risks were very low, it did reassure me to get that second dose. And I would reassure anyone to get the second dose in that the risk of complications after the second is far lower. So even if you did get AstraZeneca the first time, it would be important to get that second dose. I think the other reason is that many young people have found out the hard way recently. I know many people who've had one dose and then been infected shortly after that, perhaps before it even kicked in. And I think that reflects the poor timing of our reopening in the north. It came just as they were vaccinating 18-year-olds. So many people had done the right thing, gone to get the jab, and then been told, all right, you can go to the bars now. They'd gone to the bars, got infected, and then I think that will put them off from bothering to go get the second dose in some cases. I would still recommend that they do, but I think those kind of factors all play into hindering the uptake recently.
Right. And any comments from either of you about the difference in policy between the Republic and Northern Ireland in terms of vaccinating young people?
Well, so far, we're about to have an announcement. It would appear that today that 16 and 17-year-olds will be recommended for vaccinations, but not lower than 16, as has happened in Ireland. I would be extremely surprised if Northern Ireland departed from the vaccination policy of the JCVI because it hasn't in the past at all. And I think we have followed the UK vaccination policy and will most likely continue to do so. Children are constantly under review. I think we can still do other things well before we vaccinate children, but it continues to be a live issue, obviously. Mm-hmm. I don't think there's any chance of Northern Ireland going off on its own, and perhaps others disagree, and changing the vaccination policy alone.
Yes. I mean, I personally, of course, would be entirely in favor of vaccinating with a vaccine that is that has been approved as being safe and should be being used. That is the logical thing to do. And I do find the thinking behind this decision not to vaccinate children in the young people in the UK is very peculiar, because they appear not to have taken into account at all what we know to be a significant incidence of long COVID amongst young people, which can be extraordinarily disruptive to their education. And having at least one person involved with the JCVI at the point of making that decision who didn't believe that long COVID existed and thought it was a sociological construct, and so on, I didn't think that inspired confidence in the quality of the JCVI decision making. So that debate undoubtedly will continue.
But I think it does come back to the other point that we can't depend entirely on vaccination for virus control. And although vaccination of children, and we have a committee that looks at that, it's a complex issue, maybe a good way to go. It is not the only way to go, and we need to protect our children in a variety of ways, including ventilation in schools and all the other things that have been, and in keeping virus numbers low in general. That will also protect our children. And I think if we keep on just depending on the vaccination to do all our work for us, we'll never get on top of this strategy. So that's the Absolutely. Sense in which I would temper the drive for childhood vaccination is, well, yes, but it's not the only thing that we should be doing.
Simone, did you want to come in?
Well, I thought this was a good time maybe to go to some of the questions from the audience, because one is about long COVID and the other is about protecting the health of our children, in particular when they go back to school. So to Anthony and Gabriel and the rest of the panel, Anya Kenny from the Irish Times is asking, does Ireland need to be doing more with regards to long COVID? While there are long COVID clinics, are there enough, and are they sufficiently staffed? I know there are waiting times to be seen by them too. And do GPs need further training on managing long COVID patients? And I suppose we talk about prevention rather than cure, because it is important to not be treating large proportions of our population, especially our young people, with a very significant disability when we can prevent it. And that maybe ties in with Michael McKillen's question, which is, how do we persuade government to mandate proper mask wearing, the FP2 wearing in primary school children in class? He says he has a granddaughter age 11 and she was off various times last year off school for nasal swabs. And is there an ideological opposition to this in the Department of Education? So what can we do at the prevention end for long COVID, especially in children? And what are we doing, or could we be doing more in relation to treating it?
Okay. Would anyone like to come in on that?
Well, maybe perhaps if I start with it. We have a serious capacity problem in the Irish Health Services for everything, essentially. And we're not too bad at treating serious acute illness. We are genuinely awful at treating complex long-term illness of many kinds. So long COVID is a condition which, if it resembles the other post-viral chronic fatigue syndromes, which it probably doesn't entirely, but it's certain there are similarities, it's going to need integrated care for a reasonably large number of people over a long time. And the capacity isn't there to provide that at the moment. Individual colleagues have set up clinics, and that's a great initiative taken by them. But the space and the size and the scope of what's required is not there. There is certainly a serious piece about treating in primary care, about support for people in primary care treating long COVID. But again, the primary care is severely under-resourced. So we've managed to spend an enormous amount of extra money on our health service without tackling any of the underlying structural problems in the health service. And that's going to make it very difficult to manage long COVID. in the future, and hopefully the department will take it seriously and HSE will take it seriously, because we certainly can do useful stuff about it, but we do need the resources. We do need the bodies in the ground to make that happen.
Indeed. I think from my point of view, I think there are three things that are important. One is to actually have some data, good quality data about the incidence of long COVID, so that we can monitor it and monitor it well into the future, since we know that some of these syndromes can drag on for a long time. I think the second thing is we do need research, and that data and the research should go hand in hand to see what are the main characteristics that are amenable to intervention. And I think the third thing then is the development of protocols, so that we can have evidence-based protocols for the treatment response to people of all ages with long COVID. And those three things seem to me particularly important. I completely agree, Professor Staines, with your comment about it being different from some of the other long post-viral syndromes, and they are a very complex group. And my own daughter suffered severely from one for about 18 months and lost a year of her schooling, and she is absolutely terrified about herself and her friends getting COVID and having to go through the same thing. It's not something I would wish on anyone, and I do think we need to take it much more seriously and talk about it much more seriously. Would anyone else like to come in on this? And if yes, Dr. Ryan.
Ben, we can't hear Tomas.
No, it's not working, Tomas, I'm afraid. We'll come back to you and try and get that technical issue sorted out. Would anyone else like to come in on the long COVID? No. Tomas, do you want to have another go?
Can you hear me now?
Yes, we can.
Okay,
there you go.
Good. So thank you. It seems that the issue of long COVID in children has been downplayed in the Irish media very much over the past few weeks. The facts of the matter are that we are heading into one of a number of scenarios which have been broadly modeled by the National Epidemiological Advisory Group. The Center to Pessimistic Scenarios have us in a situation where in September or October, we will peak with more infections than we did at Christmas, or than we have at any point in the pandemic thus far in Ireland. The difference is that this time it will be the Delta variant, which we know is far more transmissible than the Alpha variant, and which we haven't yet observed how quickly it will spread in the context of Irish schools. So we are heading towards a situation where it is very likely that a large portion of the under 16 population in Ireland will be exposed to the virus. If we undergo business as normal in our schools, we can no longer accept the mantra that we've been hearing for too long, that schools are safe. In fact, schools will be the most vaccine-free congregated environment in the country as cases are rising. And when we are dealing with a vaccine-free environment, we have to also do everything we can to make sure that the environment is virus-free. And that means taking more mitigative action than has previously been taken in the context of schools. It's welcome that CO2 monitors are being provided, but CO2 monitors don't ventilate classrooms. CO2 monitors give us an indication of what kind of ventilation is currently in that given classroom. So we need thresholds for when those classrooms should be closed. We also need, I believe, much more transparent information on how a given classroom or how a given school is doing in terms of case numbers. And this needs to be reported to parents. And I think that most of the independent scientific advocacy group would support very much a letter that was published yesterday, an open letter to Minister for Education Norma Foley from the citizens group Parents United, which are calling for a number of concrete actions with respect to schools. This letter, which can be found very easily on the internet, cites the risks to long COVID for children in Ireland and proposes that we learn from other countries which have taken measures to reduce infections in schools. I think that one particularly salient point is that there needs to be a clear option for distance learning. And this option for distance learning needs to be maintained ideally until the end of the pandemic. We need to look at face mask wearing in primary school classrooms. I know nobody wants to hear that, but face mask wearing for children is a minor inconvenience relative to the risk of spread in those classrooms. And I think that we need very much clearer guidelines over when a particular classroom is shut down based on the infection in that school or in that classroom. At the moment, we're still very vague and have been throughout much of the pandemic about how schools need to operate under those conditions. And it also seems to me that there is a large place for sentinel testing of schools, even if it's sentinel antigen testing, where we're regularly screening to see whether or not cases are arising asymptomatically in primary schools that we may not be aware of. If we don't take an attitude as a country that we want to prevent infections in schools over the next few months, then we're essentially saying that the younger people in the population can simply be infected, and that will be fine with us. That will be how they will acquire immunity in the medium term. I personally don't find that very acceptable. I've had very uncomfortable conversations with my own children who are under 12 years of age, who want to know why they can't be vaccinated yet. And of course, we cannot ethically vaccinate under 12s until it is licensed for that age group, until we know that it's safe and regulated. But until then, they need to be given the choice. So I don't want to get COVID-19. I have been carefully restricting my behavior and my movements for well over a year now. I'm not fully vaccinated. I will be fully vaccinated this week, thankfully, or a week following this week. And I don't want to get exposed to the virus either, but I recognize that we're living in a society where I may be forced to be exposed to the virus, or I may be forced to having a very strong risk of being exposed to the virus. And I want to be vaccinated before that happens. And I have that privilege and I have the ability to control my movements until I am vaccinated, so that when I am exposed to the virus, I will have that protection. My children don't have that option. And my children are likely to be put into a very precarious environment. About a month from now, they will not be vaccinated this side of November, probably not this side of Christmas. And I don't think it's acceptable that we force them to be infected or force them to have a very strong chance of infection because of political expedience or convenience. We hear lobby groups every day on multiple forms of media asking for restaurants to be open, asking for pubs to be open, asking for all hotels to be open, and for the airline industry to be existing in a country that is most suitable for it to do business in. We hear very little in comparison from children, from parents groups, and from teachers. And I think this is something that we need to be taking a very serious look at in the coming months.
Thanks very much, Tomas. Andrew, there is some controversy about the incidence and prevalence of long COVID, and there have been recent reports about that, and there's different methodologies being deployed. What's your take on the state of the information on long COVID and what it shows us, particularly amongst children?
Thank you, Anton. Thank you, Gabriel. So there's a very mixed bag in terms of quality of evidence on long COVID. We've had quite a number of weak studies that can't really tell us how prevalent the disease is, and particularly in children. We've had a number of studies that are very small, don't really have a control group, can't really accurately measure whether somebody was infected or not. So they might miss the asymptomatic ones who may be less likely to develop long-term symptoms. And I think overall, the evidence from the ONS, from REACT, and from another study in the UK called Convalescence is all pointing to around a 10-15% prevalence in overall within the population following an infection. And whereas that compares to about a 1 or 2% in the control groups that some of the studies have used. So it is much higher than that. And then more recently, we have had studies in children. The ONS in particular is probably still the highest quality estimate of that. And that estimate makes it was lower in children, fortunately, and we're all glad to hear that. But it was still fairly high, around 5, 7, 9%, hovering around that area. Now, fortunately, some of those will likely be milder than the cases in adults, but we don't have good evidence on how many have life-limiting long COVID, how many actually have that impact. And I'm hoping that more high-quality studies will come out soon. We have quite a high-profile one came out yesterday, and it was met with widespread media attention, suggesting that the incidence of long COVID is fairly low in children. Now, I think that comes to the definition of what you define as low and what you define as an acceptable risk to children within the population. It suggested it was about 4% of children who had a symptomatic case still have symptoms 4 weeks later. Now, the authors define that as low. I do defining low risk all the time, and I find it very difficult on how to define what actually is low. It's lower than in adults, but I don't know if it would be a risk I would be willing to take if I had children. And about 2% of those children had symptoms at 8 weeks following the onset of symptoms. And again, 2% applied to the whole Irish school population or Northern Irish school population are quite high numbers to me. And I think that can have a considerable long-term impact if we allow it to infect every child before they get their vaccine.
Thanks, Sandra. I mean, I think that's a very important point, that you can have a low risk, but if there's a huge exposure across the population, that is a lot of cases and a lot of long-term damage done. I just want to go to Fergus Kennedy, who is attending on Zoom, who raised his hand for a question or a comment. Fergus, can I call on you to join us and ask and put your point or ask your question?
I have him there, Gabriel. Actually, I've messaged him, so we do have 2 other questions in the Q&A.
Okay. We don't have Fergus.
Okay. Maybe while Fergus is figuring out to unmute himself, and actually Ellen Rayner's just raised her hand, so maybe she'd like to ask a question live. We've a question from Chris, who is asking whether it is reasonable to rely on updated vaccines for new variants. He points out that the current vaccinations were developed incredibly fast, as we've mentioned many times before. They were in development for a long time, and we were incredibly lucky that they came at the right time for this pandemic. But is there a full sense of security now, because a good vaccine came so quickly, that this is the way to protect ourselves against new variants?
Would anyone like to respond to that from our panel? Helen, thank you.
I mean, I don't know about a false sense of security, in that I don't know that we have a very strong sense of security. We know that there are variants coming up, that it should be possible to adapt the vaccine, but that's not going to be a fast process, because it's not just a matter of the adaptation of the vaccine, but of delivery to it, of the vaccine to the entire population. And we've seen exactly what that needs this year.
I'm on losing,
I don't think we've got a strong sense of security about the protection against variants, and protection against variants has to be done through, coming back to the old point, through the virus case number control worldwide, and through making vaccines available worldwide, and really acting on the vaccine equity issue.
Okay, thank you very much for that. Did we manage to raise Fergus to join us? No. Okay. Anyone want to make some final points, because we'll wrap up today? I just wanted to make two points. One is that we should remember at all times that this is a preventable disease. This is not something that we have to tolerate, and tolerance of it, just as that discussion, I think, about long COVID pointed out, tolerance is very seductive and can appear easy, but it's also very harmful. The second thing is I really think we need to do something more dramatic from a helping schools improve point of view, ventilation, and maybe some of the approaches to testing that Tomas was talking about, and masking and so on. And we should, I think, look to producing some sort of healthy schools COVID standard that schools could judge themselves against and could be judged against, so that we know the level of progress in terms of really important issues like ventilation. Would anyone else like to make any final points before we write? Simone, please.
Gabriel, I would. And also Ronan Smith from the Irish Daily Mail has asked a question. I suppose we've talked often about citizen science projects and what people can do to protect themselves. So we're at this watershed moment now, 300,000 cases in Ireland and over 5,000 deaths, and a mixed response from the government for dealing with this pandemic. So parents can ask themselves what they can do in the absence of that response. So Parents United have written a letter relating to the CO2 monitors, which are going out to Irish schools, and the fact that the setting for tolerable air quality is very high and isn't what was recommended. And also, as Tomas has said, that CO2 monitoring is a way of like putting the canary in the coal mine, showing when the air quality in the room isn't good, and therefore the risk of aerosol spread is higher. It is not ventilation in itself. So what do you do then when the reading is high? And most schools still do not have adequate ventilation, whether it is windows that can open or HEPA filtration. And so parents groups can get together and either persuade their school individually to invest in these, or to buy them themselves, and to monitor the air in their classrooms. I think we enter this place of paralysis when things that should be done by the authorities are not being done. We forget that where we can do those ourselves, and help people that are less advantaged to buy those. The buy one, give one schemes that you see across all sorts of social causes are a way of dealing with this. So Ronan Smith has asked, we're less than a month out from schools resuming, and we have had a high level of daily case numbers. Should schools resume at all, given the high incidence and the lack of vaccine protection for children and younger people? And he has a second question about the Johnson & Johnson vaccine. If it is less effective against the Delta variant than the others, are there concerns that there's a large proportion, 220,000 people in Ireland, considered fully vaccinated after the one dose? So another question about the plus part of Vaccines Plus, as well as the vaccine part of that strategy.
Would anyone like to respond to those questions? Yes, Anthony?
I think the short answer in the schools is there is a risk there which is quite substantial, and we have to do everything we can to minimize that risk or not open. And the consequences of not opening would be bad, but so will the consequences of opening and shutting down again. In terms of vaccinations, I think the clear message is that any vaccine that's on the market reduces your risk of getting critically ill much more than you might think, and reduces your risk of dying much more than you might think. You may still get infected. People are getting infected with COVID-19 who have been fully vaccinated with any of the vaccines out there. But you're much less likely to have something awful happen to you if you are vaccinated. I think over time it will become clearer what the relative protection of the different vaccines is against different strains. One of the problems is that the studies that produce these tend to be small. So the uncertainty around the estimates of protection can be quite big. And it may be that Johnson & Johnson is less protective against Delta than some of the other variants, but it's not than some of the other vaccines, but it's not certain. But it is certain it provides a level of protection. And the analyses that have been done all say the same thing, that it's more important to get people their first completed set of vaccines, that should be the priority. And once that is done, then we start thinking about, does it make sense to give boosters to people who've had this vaccine or that vaccine, or to people who are at high risk for this reason or that reason? And that's a different question. But the first step in all of these questions is to get as many people vaccinated as possible. And that's the optimum protection for all of us.
Yes, thank you very much. One thing is clear, that COVID-19 is not going away. It is going to be with us for some time, and we really do need a strategic plan to cope with it, because of the emergence of variants, because of all the infrastructural things that we need to do, like getting safe schools, like safe workplaces, like proper masks. And we do actually need a strategic plan. And one of the big disappointments, I think, for me anyway, has been not seeing good plans and strategic plans about how to preserve health in the midst of this pandemic. I noted, for example, the Healthy Ireland Strategic Action Plan, which was published within the last few months, covering the years up to 2025, and very good it is. And what we need is a strategic plan for this year and for next year to keep us safe from COVID-19, including how to prevent variants as they emerge arriving into Ireland and undermining some of the protections that we are getting from the very welcome vaccination programme. On that theme, I'd like to close for today. Thank you very much for attending and for posing those questions. I hope you have found it interesting. Do have a look at the ISAG website and the ISAG Twitter channel, and you'll find details there of our meeting the same time next week. So have a safe week until we see you next. Thank you very much.